Hello, welcome to this presentation. We are a Spanish team. We come from Granada and we work in the pain unit of the Hospital de Alta Resolución de Guadix in Granada. We have conducted a study about opioid-induced constipation in chronic pain. The director of the unit and main investigator here is Dr. Velázquez Rivera, and he has been assisted by two members of his team, Dr. Sánchez del Águila and nurse Mrs. García Velasco. It's a pleasure to share the results of our work with all of you. Chronic pain is a major cause of disability worldwide. In Spain, chronic pain affects about 12% of the population, being severe in about half the cases. Pain treatment involves a multifaceted approach, and the goal is to reduce pain and to improve the patient's quality of life. Opioids are the mainstream analgesics for moderate to severe oncologic pain, and they can also be used to treat chronic non-oncologic pain when other treatments do not provide the necessary relief, and obviously when the risks associated with the use of opioids are considered as low. The binding of exogenous opioids to mu receptors in the gut can lead to the so-called opioid-induced bowel dysfunction. This is a group of gastrointestinal symptoms such as reflux, abdominal cramps, bloating, changes in intestinal transit, and constipation. Opioid-induced bowel dysfunction, OIBD, is a common side effect in patients taking opioids, especially women. Clinical studies provide different estimates of the prevalence of OIBD in cancer-free patients, ranging from 15% to 95%. However, in recent years, two new opioids have been developed that have an improved profile, including the reduction of gastrointestinal adverse effects. To look at the degree of constipation the different opioids produce in our population, we conducted a cross-sectional observational study of a single center. It took place in the pain unit of the High Resolution Hospital in Guadix, Granada. The study was carried out in accordance with the principles of Helsinki Declaration, and it was approved by the Ethics Committee of Virgen de las Nieves Hospital in Granada, Spain. The data were obtained from the patient's medical history and from the interview during the programmed visit and included the following: age and gender, underlying disease, type of pain, type of opioids the patient was taking, dosage, and state of intestinal function according to the Bowel Function Index, BFI. Also presence of previous constipation. Our main goal was to assess whether there are significant differences in the BFI values associated with the type of opioid treatment given to the patient. The inclusion criteria were as follows: 18 years old or older, moderate to severe chronic pain treated with strong opioids, according to WHO 3 analgesic scale, for at least 1 year before the visit and the patient's informed written consent. The exclusion criteria were cognitive impairment of other conditions that prevent the subject from answering the BFI questionnaire. Statistical analysis. Categorical variables were described by absolute and relative frequencies. Pearson's chi-square test was used to analyze the association between two categorical variables. As for continuous variables, they were described by mean, standard deviation, median, and range. Kendall's tau b was calculated to analyze the association between continuous variables. Differences in continuous variables between groups were estimated by the Mann-Whitney test in the case of two groups, or the Kruskal-Wallis test in the case of three or more groups. As for the statistical significance threshold, the p-value was set to 0.05 for statistical tests and to 0.95 for confidence intervals. "180 patients were included in the study. Data from all patients were included in the analysis. Most of the study participants were women. The median age was 61.5 years, range from 35 to 91 years old. Most of the patients, 57%, suffered nociceptive pain or mixed pain, 34%. There was a minority, 9%, who had neuropathic pain. The most common reasons for prescribing opioids were lower back pain and osteoarthritis. Only 8 patients, 4.4%, had oncologic pain. 51 patients, 28.3%, already suffered from constipation before starting their opioids treatment. The patients had undergone the treatment for an average of 3.1 years, with a range of 1 to 6 years. Most of the patients with neuropathic pain or mixed pain were treated with tapentadol. As for individuals with nociceptive pain, oxycodone naloxone was the most commonly used opioid to treat them. The most commonly used opioids were oxycodone, naloxone, 44%, tapentadol, 38%. The average dose of tapentadol was 225.7 milligrams a day, and for oxycodone, naloxone, it was 27.8 milligrams a day, corresponding to a ratio of 8.1 to 1. Neuropathic or mixed pain, mostly treated with tapentadol, is often more resistant to treatment, which could explain that higher doses of tapentadol were required. When equivalent doses of morphine were compared for all drugs in the 77 patients with mixed or neuropathic pain, no significant differences were found between the different opioids. The same happened when the comparison was performed for the 103 patients with nociceptive pain. The average BFI score of the participants in our study was 43.4. For patients treated with oxycodone naloxone, the average BFI value was 40.4. For those treated with tapentadol, the value was 41.6. And finally, for those who consumed other types of opioids, the average BFI was 55. BFI scores differed substantially between opioids, being lower for oxycodone, naloxone, and tapentadol, and higher for hydromorphone and fentanyl. P equals 0.016 according to Kruskal-Wallis test. There was no significant difference in the BFI score between oxycodone, naloxone, and tapentadol, P equals 0.6 according to Mann-Whitney test. So in patients treated with fentanyl, hydromorphone or buprenorphine, a higher percentage had BFI scores indicative of severe constipation compared to those treated with tapentadol or oxycodone naloxone. 133 patients, 73.9%, had a BFI score over 29, which is indicative of constipation, and 39 patients, 21.7%, had a BFI score over 69, suggesting severe constipation. Of the 51 patients, 28.3%, with a history of prior constipation, 31, 60.7%, reported worsening symptoms after starting the opioid treatment. So our data suggest that most patients chronically treated with opioids have symptoms of constipation, and about 1/5 of our study population suffers from severe constipation. Tapentadol and oxycodone naloxone showed a more favorable profile of intestinal function than buprenorphine, fentanyl, and hydromorphone. No differences were found between tapentadol and oxycodone naloxone, although equivalent doses of morphine were, on average, higher in the tapentadol group. Other predictive factors for stronger constipation were the equivalent dose of morphine and a history of constipation prior to opioid therapy. Well, that's all. Thank you very much for watching, and we really hope that you liked the presentation and that you found this information interesting and useful.